Hello and welcome. I'm your host, Ramesh Kumar, and I'm on a mission to bring value to the healthcare industry through improved transparency. And my goal from this podcast is to give you one aha moment that you can implement in your business, whether you're a TPA, broker, or an employer. In my day job, I run a company called Zaki Point Health that helps self-insured employers and their employees provide transparency, direction, and value by delivering a digital front door for the member that proactively steers them. Please like or share this podcast on your favorite podcasting tool so we can bring together a community of like-minded professionals. This program is brought to you by the Healthcare Administrators Association, HCAA. For over 40 years, HCAA has supported third-party administrators and the self-insured employer industry through educational opportunities from leading industry experts. For information on joining HCAA, please visit our website at hcaa.org. Our new sponsor for the 2024 season is Valence Health. Valence Health is the platform to simplify healthcare, the destination for employers, payers, providers, and members to reduce costs, improve quality, and elevate the healthcare experience. The Valence mindset and culture of innovation combines to create integrated solutions. Valence engages early and often to execute across the entire patient journey, from care navigation and management to payment integrity, plan performance, and provider verification. With a 99% client retention rate, Valence Health elevates the expectations to a new level of efficiency, effectiveness, and transparency where smarter, better, faster healthcare is possible. For more information, visit valencehealth.com. I have with me Paul Ashley of NFP to talk about PBM contracting and many, many other things. Paul is not only a successful benefit consultant with over 22 years of experience in the upper middle market, with extensive experience of helping employers put together an affordable plan. He is a sommelier and is offering to host an event talking about wine for your nonprofit. And in this episode, we are covering things like PBM contracting, specialty pharmacy trends, RX carve-in and RX carve-outs and approaches and the savings associated with it, and how to use the data from PBMs to manage costs and deliver transparent PBM services to your employer. So let's dig in. Welcome, Paul, to our podcast today, Voices of Self-Funding. I am super excited to have you and for you to share your thoughts. But rather than me introducing our topic around pharmacy benefit contracts, and some of the things that are going on underlying that in terms of the costs and transparency, I'd love for you to share with our audience, why should they listen to you? What is your expertise and what's been your journey?
Well, it's a pleasure to be on the podcast with you, Ramesh, and all the great listeners out there. Boy, I don't know if they should listen to me. And I'll say that I've been in the employee benefits consulting space for well over 2 decades, I think 22 plus years at this point. And over that time, I've certainly gained knowledge around self-funding, cost containment, and definitely recently in the last 10 years, spent quite a bit of time learning and perfecting skills and knowledge around the pharmacy benefit management world. Because if you're a self-funded employer and you're trying to offer competitive benefits at a fair price, you cannot ignore what's happening in the RX world. And then obviously the PBMs you choose make a huge difference. So I work as a consultant in that space, dealing primarily with employers between, I'd say, 500 and about 5,000 employees. So that upper mid-market, primarily domiciled in the Midwest, although I have clients on the Eastern Seaboard as well. And I'm based out of our Indianapolis office.
Wonderful. And I know you host a podcast. Tell us a little bit about your podcast as well.
Well, it's certainly not as well regarded or as famous as your podcast, sir. However, we started a podcast, myself and a coworker. Her name is Anna. She goes by Anna B on the podcast. So myself, I like to say I'm a washed up old Gen Xer in my late 40s. She's a very young, intelligent, spry Gen Z. She just graduated from college about 1.5 years ago. She's 24 now. So 2 different generations talking about the workplace, but also exploring total rewards. So we focus a lot on employee benefits. We focus a lot on compensation. And really, what are the things that attract and retain top talent to run organizations. And so that podcast is called the Work Dad Podcast with Paul and Anna B. And people say, why are you doing it? And our number one reason, Ramesh, is to have fun. And if we ever stop having fun, we're going to stop doing the podcast. But so far, 7 episodes in, we're having a grand time. Got a lot of great feedback from listeners, old and new. And so we're going to keep pressing on until somebody tells us that it's stupid or we stopped having fun.
So listeners out there, make sure you check out Work Dad podcast. Initially, I actually thought it was your daughter somehow that you are doing this with her. But sorry for that confusion on my mind.
Yeah, it's interesting because I have 5 children. My oldest is actually just a tad younger than Anna. She is 21, getting ready to graduate from college next May. So the age that Anna is as a colleague and the age my daughter is very similar. So that's been a fun part of exploring that relationship and sort of seeing my daughter through Anna and vice versa. So we're having a joy. It's a good time.
That's great. That's great. My oldest is just headed to college in a few weeks. So it is exciting for her. I'm very excited as well because college was a great time. But there are a couple of other things that really connect us deeply, aside from healthcare, podcasts, and pharmacy benefits that we'll be talking about. One, I noticed you are a wine connoisseur. Not that I am a wine connoisseur. I just enjoy drinking it. But I gather you have done events. You are paid to do these things.
Yeah, so my first job, well, actually, I was still in college, and my senior year of college, I worked at a fine dining restaurant, and the owners of that restaurant did a really good job teaching the staff about wine, and that planted for me at age 22 a seed that never stopped growing. And so I explored wine and wine education and did some wine trips. And for my 40th birthday, my wife said, that's it. I'm done with you playing around. I have purchased, here's a gift certificate, if you will, for you, Paul, to go to the Court of Master Sommeliers and study and sit for the level 1 introductory exam, which I did. And so I'm a level 1 Somm. I've done some continuing education. As part of that, what I really enjoy doing, Ramesh, is helping nonprofits do special events where I donate my time as a Somm, help them go out and procure wine that will be interesting to their guests, obviously at a fair budget price, helping them be within budget, and then doing an hour and a half of wine education to create an experience where people share time together over a great bottle of wine and maybe even some food. And so that's just been a joy to give back to my community in that way and help them raise money and create connections. So that's what I do. And myself and a buddy, we have an Instagram under IndySomm, INDYSOMM, where we don't monetize that at all. We review wine and write about it and give people tips on what wines we like, and hopefully they get a lot of knowledge out of that as well.
So good to see how you're combining your passion, skill to contribute and support nonprofits. So really nice to hear that. This is good. And then we have just discovered today cricket, which one of the phrases that I know some of our listeners may or may not know cricket, but both you and I share some knowledge and passion for cricket. One little story I would share is, so my daughter, youngest one, is playing softball. And whenever I go and watch the game and a batter leaves the ball, I end up saying involuntarily, well left, because that's a phrase from cricket where when a ball is coming really hurling down at 100 kilometers per hour and it's swinging out and it might hit your head or whatever, or it might be a difficult ball to play, you just leave it and the batter leaves it, and it's called well left. And my wife always laughs at me like, where is that coming from? Well left. So that was something that I'm learning how to make sure I understand the game of softball as well.
Well, you can certainly take the boy away from cricket, but you can't take the cricket out of the boy. So good for you, still loving your childhood game.
Yeah, it's been fun. So, well, we're here to talk about pharmacy benefits. Why don't you help us first frame the conversation and really help us understand what is going on today in these pharmacy benefit contracts? What are some of the trends that you're seeing as you're helping your customers?
Yeah, I think this could be seen as fortunate or unfortunate. The trends really center around increasing costs because there's some amazing drugs coming out. So just unbelievable pharmaceutical technology that's being released to the market. And it's treating, in some instances, curing disease, even rare conditions that we thought were incurable with, for example, like gene therapy. But those are coming at a hefty price. And if you look at the average self-funded plan, We always feel pretty good when the RX spend makes up 20% or less. As it starts to rise towards 30 or higher, they probably have a challenge with a higher percent of specialty and or gene therapy medications. And if you think about specialty as a category, I would say most plans, if you look at their drug spend, easily 50% of their RX cost, if not more, 50 to 75%, quite frankly, is coming from just a handful of medications in the specialty category, really driving some pretty significant price challenges. And so employers have to be thoughtful about how they design their pharmacy benefits. And I would say even more thoughtful about the partners they choose. And that's where we get into that acronym of PBM, which obviously most listeners know, but that's a pharmacy benefit manager. As a self-funded plan, you're contracting with a PBM to help facilitate your benefits on the pharmacy side. And so that becomes really important.
Yeah, so I was just going to ask you around pharmacy benefits, carve-in and carve-outs. What are some of the
Yes.
benefits monetarily and also other flexibility that the employers can get and they should be thinking about?
Yeah, so let's define those two terms. So carve in is what sort of defaults have happened. So if you're a self-funded plan working with an insurance carrier or some TPAs, so insurance-led ASO environment, you're typically going to default to what they call their carved-in PBM. And in most cases, that insurance ASO contract, that insurance carrier ASO contract, they almost always own their own PBM. So you think about Anthem Blue Cross Blue Shield has their own PBM, Carelon RX. You think about United Healthcare, ASO, they own Optum. And so they have financial interest to keep those two things together. And I don't blame them. They're great companies trying to return value to shareholders. Carve-in can be good because it's administratively more simple. There's less moving parts. It's one simple partner. You could certainly say the data integration between the PBM and the ASO model is more easy to integrate because it's native. And it's hard to argue the fact that, that data integration is turnkey and set up. The challenge, though, is you have less flexibility with plan design. You almost never have any audit rights. And then the carve-in models tend to be less transparent than more transparent. And that can certainly cause some problems. On the carve-out side, what you're saying is I, the self-funded plan sponsor, instead of using the default carved-in option, I'm going to go out into the open market and I'm going to, through the help of an advisor or a pharmacy benefit management consultant or on my own, I'm going to go choose my own PBM partner and bolt it into what I'm doing. There you tend to get tons of audit rights. You get access to the claims data. You get to see typically transparent pricing where there's no spread pricing, where you have full rebate capture. You have the ability to audit what's happening, and it's really, truly transparent. On the carved-in side, you're typically not paying an admin fee, but there's some hidden revenue sources that the carved-in PBM has. And on the carved-out side, assuming it's transparent, you are paying an admin fee, but there is no hidden fee. So it's a little bit of a math equation. And do you value transparency or not? Do you want it to be simple or more complex?
And so what kind of monetary benefit can we see? What is the latest trend if you were to carve out? Are you looking to save 5, 10, 15% on pharmacy costs?
Yeah, if you go from what I would call one of the big four PBMs where you're directly buying in a carved-in approach, and then you shift to a carved out where you're negotiating a contract, I think on the low end, you can see 15 to 20% savings. And on the high end, you can see 30 to 40% savings. And you're like, well, that's a big range, Paul. What creates the difference there? I think what creates the difference is A, the partner you choose, and B, how much of the clinical programs that can be put in place to help offset the cost of specialty will work for your population. And a good example of that, Ramesh, is that a lot of times pharmacy benefit management companies are, especially in the transparent carved out model, they are putting in patient assistance programs. However, to qualify for some of that patient assistance, the household that's receiving the medication has to have a household income that's at or below a certain threshold to get the use of some of those programs, which defray the cost to the individual in the plan. Well, if the specialty meds are being taken by higher income earners, that's going to dilute the savings potential you have with some of those patient assistance programs. And so there's a range, it sort of depends, but I would say on the low end, 15%, and on the high end, 40% of your RX spend could be saved by proper implementation of thoughtful PBM program.
Got it. So those obviously manufacturers coupons or these special programs makes total sense. But there's a whole bunch of other things you can do when you are carving out. There are a whole bunch of strategies. You could move people injectables from one place, from a hospital setting to the clinic setting. You can mail order programs. Maybe tell us what are the levers when you are carving out that you have available to you to
Well,
leverage.
yeah, I think assuming we're in a transparent agreement, the thing that you would immediately save, regardless of the programs you're putting in, is you would get full rebate capture, but you would also remove what's called spread pricing. And so in a lot of PBM contracts, especially the big four, what you see is the pharmacy benefit manager is able to acquire the drug at a wholesale price. However, when the member of your plan goes to fill the drug, it's being sold at the wholesale price plus a markup. And that spread pricing, that difference is kept by the pharmacy benefit manager. It's why they say, well, we don't charge you an admin fee, but they're more than making up for it with spread pricing. So that goes away. When you start pulling additional levers, you get into things like you mentioned infusions, and boys, this is a soapbox I love to get on. So a lot of times medications that are done on an outpatient basis through infusions, instead of those medications passing through the pharmacy benefit manager, they tend to get sent through the medical plan. And when those providers are buying those drugs to do infusions, they buy the drug at a wholesale price and then submit the claim to the medical plan through the medical plan at a markup of 2 to sometimes 800%, 2 to 8x. Well, if you can do a J-code redirection, which requires that the TPA you're working with is in partnership with the PBM you're working with, they don't have to be owned, but they have to work together. What we typically do, and what for our clients is, we do any infusion that is non-oncology. So oncology we don't touch, but any non-oncology infusion, we have the purchasing of the medication redirected through the PBM so that it's bought at a fair price, not marked up by 2 to 800%, and then still done at the point of service or point of care that they choose to do it. Now, sometimes the doctors get a little challenged by that because it's removing a revenue stream from them. But what we're trying to do is high quality healthcare at a fair price. And so sometimes they have to move site of care. Sometimes they have to go to home infusion for that to work. But again, we help partner with PBMs that make that clinical transition as smooth as possible. And again, we never touch oncology on those J-code redirections because that's just, quite frankly, too volatile and too dangerous for those oncology patients.
Yeah, there are a whole bunch of PBMs at a recent count I saw for one of our TPA customers. They had 30 odd PBMs that they're working with. I'm always curious, beyond the top four that you alluded to, where there may not be that much transparency and they're carved in, or all the rest, 26 in this case, are they all transparent? How should the market be reviewing these PBMs? What should they be asking for to pick the right PBM? What should they be looking out for in the contract?
Yeah, I always say that pharmacy benefit managers don't underwrite risk, they underwrite contract language. And so these PBMs have more attorneys than you do, and good luck. However, if you can get with an advisor or a PBM consultant that really knows the contract language, that's probably your best bet. However, what you're looking for are things like no spread pricing, full rebate capture, the ability to access data, that you as the plan sponsor own the data in partnership with the PBM, that you have full audit rights. That's both claims audit and operational assessment rights. I also say it sounds like a good idea to enter into a multi-year agreement on the PBM side. The drug pricing is changing so quickly. I actually tend to recommend people enter into 1 or 2 year agreements at the most. So you want to make sure you have a fair duration of the contract and that any early exit penalty is well understood and something that you can work through. I'd say I have my favorite 3 transparent. They're not the only ones. In no particular order, TrueRx, TrueScripts, and SmithRx are 3 favorites that I've attached myself to, where I've really found that their contracts are fair, the way they go to market is fair, and they tend to do a really solid job. Now, that's sort of on the far right, that transparent, if you're looking at versus carved in non-transparent traditional. There's a middle rail where you get into these pharmacy coalitions where you have a buying group that comes together and they take the standard contract that you get from the big 3 or big 4. They, because of their size, multiple millions of lives, they're able to get better contracts than if you go direct to the big 4. And then those coalitions tend to wrap it with really helpful concierge services because, quite frankly, the big four left to their own devices, especially down market, don't have a great service model all the time. And so a stepping stone between carved in, traditional, if you're not ready to go all the way to carved out transparent, you can find one of these PBM coalitions. And there are many out there who can be a middle step before you go all the way to transparent.
And then who are these PBM coalitions? Are they PBMs themselves, or I'm not fully understanding. Give me some examples.
Yeah, so RX Benefits is one that operates out of the South. A lot of the consulting firms have one. So Aon has a coalition. NFP has a coalition called RX Solutions. I don't know the names of all of them, but Mercer has one. So the big consulting firms have created these, and clients can either opt in or not into the coalition. It's not something they're required to be a part of, but it can become a nice stepping stone for folks who want that household name but want to improve the contract.
And then where do things like Kroger's PBM and Costco's PBM, and where do they fit into this whole picture?
If you think about CVS Caremark, you have both a retail chain in CVS, but also a PBM all looped into one. Kroger has their piece. I was hoping that our friends at Amazon would enter into the PBM space full bore, but they've nipped around the edges because I really think they could be a massive disruptor in the PBM space with their supply chain and their excellence in procurement and doing so at a fair cost. I think they could really disrupt the market. You, of course, have folks like Mark Cuban and Mark Cuban Cost Plus, which has become a disruptor. And by the way, people are like, how does Mark Cuban do it? Well, guess what he's doing? He's doing that spread pricing thing I talked about, but he's doing it completely transparently. He's saying, listen, there is a wholesale price for these drugs we sell. We are telling you up front, we're taking the wholesale price and adding 15%. So he's transparent about the spread pricing and doing a markup of only 15%. He's coming out ahead on most drugs versus traditional PBMs. And so that's how Mark Cuban's doing that. And I appreciate it. It's a transparent, completely honest model. And it actually, the pricing works and beats most normal spread pricing, which is fantastic for the consumer.
So in some ways, the traditional PBMs are working on a much higher margin. Do you have a sense as you have analyzed the data? Is it 30%?
Yeah, I don't know if I could say that. I'll say this anecdotally. If we go back calendar year 18 or 19, pre-pandemic, so the whole space-time continuum's got me messed up, but Anthem Blue Cross Blue Shield, now Elevance, announced that they were going to bring their PBM back in-house, and they set a date of 1/1 of the following calendar year. But then what they did is they sped up the launching of that internal PBM to like April of the year prior, and their stock price skyrocketed because Wall Street knew by them having a PBM, it would deliver so much to the top and bottom line of Elevance at the time, Anthem, that Wall Street loved it. So there's no doubt that PBMs can make a tremendous amount of money. I think I prefer the sort of carved out transparent that are making a fair amount of money, but putting fair price and patient outcomes first. That's my preference as a consultant.
Another area, Paul, that would be really helpful to get your direction. TPAs out there who are going out, putting these 30, 35 PBMs hooked into their systems, or any new employer with a new broker partner is saying, okay, use this PBM, use that PBM. What is your recommended approach? It sounds like you got the top four because that's got the market share. You've got these 3, 4 on the transparent side, some ways, and maybe one somewhere in the middle. What's your general advice? How can they streamline this?
My advice is to generally look to move from less transparent to more transparent, less control to more control. And for each plan sponsor, that appetite and desire is going to be stronger or less. I don't know that they're really wrong answers as long as you're moving on that spectrum, as I say, from left to right, because I can picture a page that we have that sort of talks about that movement from left to right. I don't know if you wind up linking that in your show notes. But again, if you're steadily moving from less transparent to more transparent, from carved in to carved out, just over time, slowly, I think you're making progress. And as long as you have a great advisor or an independent PBM advisor that's working on your behalf that knows this market well, sort of who the names are don't matter as much as do we have the right contract? Do we have the right communication to employees in place? The partners can be somewhat interchangeable. Of course, you don't want to change PBMs every year because that would be very disruptive to the population. But I think it's about making that move slowly over time.
Got it. So keeping that broad framework in mind. It'll be helpful for our audience to take one or two case studies where you've applied these levers, you've changed it to a transparent PBM, what kind of savings you saw, how can somebody else who's listening to this take that and say, you know what, let me at least get 50% of the value by doing these things?
Yeah, happy to. One that comes to mind is a durable medical equipment, medical device supplier based in the Midwest, employees all over the United States. When we met them, they were about 250 employees and they were fully insured. They started organically growing. They'd made a few acquisitions, got themselves to about 400 employees, and it was time to move to a self-funded environment. And in doing so, we knew within the risk data of the population, there was some pretty meaningfully expensive specialty drugs. And as we were contemplating the move to self-funded, we knew we were going to have to reckon with that. And so we helped them choose a carve. They went with UMR, which is the independent TPA division of United Health Group. UMR does allow a carved out transparent relationship. You can choose plug and play your own PBM, at least in our market, as long as you have 100 or more enrolled, which they were there. And so what we were able to do was flip to a self-funded arrangement, implement a transparent PBM, and in doing so, versus what the claims would have been with a standard traditional PBM, we were able to cut out about $55 per employee per month of claims cost. And that happened because what they put in is, I'll sort of describe the model. They put in what I call a soft exclusion. So in other words, it sort of defaults as specialty medications are excluded from the plan so that the PBM and some of their third-party partners they work with can go and explore any patient assistance program. If the patient assistance fails, then they offer up voluntary international sourcing. And voluntary is very important because you can't force it through the plan. That would violate quite a few federal laws. And if that doesn't work or fails, then it comes back to the plan to be covered. And so doing that, like I said, in the case of this, saved about $55 per employee per month. Well, you multiply that by, at the time, 400 employees times 12, that's a chunk of change. That same client now is about 600 or 700 lives, and they're continuing to keep their total spend price way down. They probably have claims, when you include medical and RX combined, they're around $550 per employee per month. So pretty healthy group, and they pulled a lot of levers to save money. So that's a good example, yeah.
Oh, that's great. That's great. And any other kind of for larger group or a different kind of difficult group where you had to put all kinds of things in place to really save on costs?
Yeah, another group where we did this similar model, about 1,000 employees. They added to that the J code redirection. So in partnership with their third-party administrator, they told the deep TPA, if a claim comes in with a infusion J code that's non-oncology, you need to decline it and send it back to us so that we can source it. And there's not a lot of people on non-oncology infusions, but if you have 2 or 3, 4 or 5 people, you can easily see your RX spend on those previous J-code medications now that they're flowing through the PBM. We typically see price reductions of 20 to 50%. So an infusion that somebody was spending maybe 60 grand a year on now is cut down to 30. That's still a lot of money, but those dollars add up, 2 or 3 different infusions per month across the population. And so that's another good example. And that required, obviously, the plan sponsor, and then the TPA, and then the PBM to all be in concert with each other. And certainly it's not very many people affected by it. And so you've got to do really targeted education and communication. But when you do that, it can have great outcomes. And the people love it because they see themselves spending a little bit less time and money. A lot of times it shifts to home infusion, which quite frankly for the end user patient, as long as it's clinically appropriate, is a way more comfortable spot to have infusion than some outpatient center.
So did you say $20,000 to $30,000 per month savings?
Yeah, per infusion. And some infusions are monthly, some infusions are every 6 to 8 weeks. So it really depends. It's a lot of it's some of the rheumatology and arthritis drugs that get infused. But again, just to be clear, we never recommend that oncology drugs get redirected. That just needs to stay in the medical plan. And while you could save money with J-code redirection of oncology, it really will disrupt the patient experience too significantly and really in an unsafe way. So we never touch oncology.
Makes sense.
Yeah.
Obviously, that's one big area strategy. There are other trends that we are seeing that are driving up a lot of the costs, and in fact, confusion, GLP ones.
Ooh.
What is your kind of approach and strategy, what do you recommend to the employers?
Yeah, that's a great question. It's a hot topic, right? So let's talk clinically. I'm not a physician, nor do I play one on TV. You can't deny, though, that GLP-1s clinically have been unbelievably successful, obviously for the treatment of diabetes. Now approved for the better part of 2 years for weight loss only. Recently approved for cardiac protection. And in the future, every expectation is there'll be other approvals that include but are not limited to addiction therapy and some neuroprotective properties like dementia, Alzheimer's, that sort of thing. As we wrestle with this from a weight loss perspective, it works. And now it works best when it's clinically guided, physician directed, done in partnership with other interventions so that hopefully the person can use the GLP-1s to kickstart their weight loss journey, get to a new set point of weight, start to come off those medications so they're not on it for a lifetime, and be able to maintain the weight loss. And that requires the employee, the patient, the physician thinking thoughtfully about this. I interviewed a doctor recently, Dr. Jonathan Schmidt, who's part of a direct primary care practice in Indianapolis. He just wrote a book called Take a Load Off. It was about his personal journey of weight loss using GLP-1s and with his patients. And I asked him this question, Ramesh, which is, assume for a second you're the medical director of a large self-funded health plan. And you're sitting across the table from the chief financial officer. And the chief financial officer, he or she asks you, Dr. Schmidt, should we cover GLP-1s? What is your answer? Because if you're asking me the ROI question, my answer is simple. If your turnover is low, then you probably should do it because you're going to pay money up front but save a ton of money on the back end. If your turnover is high, you probably shouldn't do it because you're going to pay a lot of money up front and you're going to be saving some of their plan money. And so I thought that was a really thoughtful answer because he clinically believes when physician guided, these are undeniably good drugs, but he's answering the ROI question, which if your turnover is low, and he defined that as less than 25%, it's kind of a no-brainer. If it's between 26 and 50%, it's a maybe. If your turnover is 50% or greater, it's probably a watch out, right? But he said, if you're asking me, Paul, if these clinically work, it's undeniable. When they're done right, these work extremely well. So the things that employers are putting in place when they're considering GLP-1s for weight loss is utilization management, maybe step therapy, some eligibility requirements. We've seen annual maximums. What I really like is the idea of a lifetime maximum, that you would have a lifetime maximum benefit for using GLP-1s for your lifetime under a plan. I think that's smart, but it clearly has to be physician guided. That's the danger when folks go off and do this on their own. I just don't think it's smart personally.
So there's a bit more caution, get it through some medical program review, whether it's a diabetes program. Often they have very well developed thinking on whether to include GLP-1s or not.
That's right. Most employers include GLP-1s for the indication of diabetes. It's the hottest of hot topics right now with our self-funded plans of whether they want to add GLP-1 coverage for the purpose of weight loss, right? So almost everybody, like nearly 100%, cover GLP-1s for type 2 diabetics. The real question that self-funded plan sponsors are wrestling with is, do we add GLP-1s for weight loss only as an indication? And that's not an easy answer. It's an expensive answer because these drugs cost $900 to $1,500 per person per month. They're expensive.
Wow. There's obviously another whole class of things like gene therapy that has been approved and that sometimes can drive costs, but also has huge benefits. What is the approach you've taken there?
Yeah, so the gene therapy ones, that can get scary, right? So if you think, what is gene therapy? These are drugs that treat or prevent diseases by adding new copies of a gene to replace the ineffective or copy of the gene and replace it with a new gene. A little bit of mRNA technology. Again, I'm not a scientist, so don't quote me on the details and get a scientist on, Ramesh. But some of these drugs are amazing. There's one out there now that cures, for the right clinical reason, cures inherited blindness. But this is a drug that costs almost $2 million. And so how do you wrestle with that? And I think what we're headed to, what I believe will happen, and it's in its infancy, I believe we will wind up with some sort of, you know how self-funded plans today, Ramesh, can put in special stop loss for transplant only, so transplant stop loss, but it almost makes any transplant expense feel like fully insured to the plan. I think we're going to wind up having a capitated charge that sort of every self-funded plan pays a little bit of money and winds up fully insuring the risk of these high-end gene therapy drugs, or maybe federal or state governments step in and create a buying coalition for just gene therapy, because if any single one of these gene therapy drugs hits a plan, it can cripple a plan. And so a lot of this is being excluded now and thinking about how do we do pay arrangements and stop loss carriers to spread out the financial risk of gene therapy, because it's just not something that a single employer can sustain on their own without a lot of working capital. So it's a real challenge. But if it's your son or daughter who needs this gene therapy, there's no price that's too much, right? So that's the challenge.
Yeah. So at a societal level, we certainly don't want to alienate that individual family. So finding these structures through stop loss or through government, maybe assistance you might imagine happening in the future. But certainly it's an area to watch out for.
No doubt. Yeah. And I think something that's causing downward pressure on another trend is biosimilar drugs. So if you think about in 2023, you had the first biosimilar of Humira, which the Humira drug was a blockbuster drug, right? For a decade plus, Humira was the leading total gross spend drug out there. And what happened was in 2023, I think Amjevita was the first biosimilar. And I always tell people that these biosimilars, it's not technically accurate, but it's the generic of specialties. It's not exactly right. The science isn't right. But as a generic oral medication is to brand name, similars sort of are the same thing to the specialty injectable. And so you're going to see more biosimilars come online. Those biosimilars aren't cheap, right? They just tend to be 40 to 60% less than the brand name version of it or the original version. And so biosimilars could come along and really put some downward cost pressure on what are very expensive drugs, like Humira being replaced with Amjevita. And we're seeing that to be about a 40 or 50% reduction. And so formularies are making adjustments to shift Humira from the preferred list to the non-preferred and put Amjevita on preferred. And obviously, when you get into the PBM world, you also have to deal with what about the rebates? So what's the lowest net price? So that gets a little complicated, but no doubt biosimilars are putting downward pressure on a class of drugs for sure.
So things that could also be thought through in the contracts too, and how the PBM is using biosimilars or not.
That's exactly right.
Yeah. So kind of let's bring the conversation back up a little. These are some great strategies and things to watch out for in the contracts. As you work with employers, what are some of the steps you recommend them taking to really optimize these things? What are the 1, 2, 3 things they should be doing?
Yeah, I think number one is when we meet a new client or a client who hasn't made much progress in this area, we will start with a analysis. So we take 1 or 2 years of all of their RX claims, and we analyze it through what it would look like through a different, more transparent or fiduciary contract. And in doing so, it illuminates where the cost savings could be or where the cost expenses could be. And that really helps an employer make dollars and cents decisions. How would the contract improve? What are some of the clinical programs we could turn on or not? And if we pull certain levers, what is the range of savings we could create? And then that gets presented to the employer, and then they make decisions. Now, change management can be tough. So if we think about where a member of a plan has lots of touches with the health plan, the RX benefits is a big one, because a lot of times people are filling maintenance drugs every month or every 90 days. And so making a PBM change should not be done hastily or at the last minute, because if you're putting some of these cost containment programs in place, you definitely want to particularly formally talk about and address for those you know are going to be impacted well ahead, so they can put some stuff in place before the change happens. For example, we have a lot of clients that are considering 1/1 of 25 PBM changes. So this next calendar year, they're making decisions now or have already made decisions so that in the 3 to 4 months preceding the change, we can actually get out and talk to individual employees about what the change will mean to them. So I think it's a financial analysis. It's a change management communication program. And then it's the third item I would add is, as this is going, you start to measure what are the outcomes we're seeing, and are we getting the outcomes we expected, so that you can work with the PBM to dial things up or dial things down as the contract unfolds.
In that case, are you taking the data on a monthly basis to be able to see which dials are working, which dials are not working? Are we seeing manufacturer coupons being used and this and that? How are you doing that?
Yeah, so for us, for all of our clients, all of our self-funded clients for sure, and some of our larger fully insured clients, we put all of them into a data analytics system. We use a third-party technology called Springbuck. And what Springbuck lets us do is get total claims data from both TPA, carrier, and PBM loaded into the file. We can go back and look in rear view what's happening. And then we can also project forward what's happening using the Springbuck tool to create insights. That tool also lets us create a focus population. So we could create a focus population of folks that we knew were on specialty meds. And we can start to look over time, these 30 people out of 1,000 that were on specialty meds, what's happening to their claims over time. And so we can isolate and track that month over month over month to start to see the savings come in line and report that back to the plan sponsor.
Great. So I guess the role of data on an ongoing basis can be really valuable to track these contracts.
Yeah, absolutely, for sure. And I threw out a term there a second ago, fiduciary. There actually is one step past transparent called fiduciary. And this has really come in the news in the last couple of months. So the first lawsuit was against J&J. There was some former employees who are suing J&J as an employer plan sponsor for breach of fiduciary duty because they don't feel that the PBM arrangement they had in place was proper and didn't fully benefit them. And then I think just last Wednesday, somebody sued a similar lawsuit, class action lawsuit, sued Wells Fargo for the same reason. Now, if I'm the average employer out there and I'm not one of these big, massive employers, I probably don't get too worried that I have a target on my back yet. But I should take these lawsuits that are happening around fiduciary requirements that you have as a plan sponsor very seriously, in the same way you take fiduciary responsibility of your 401k retirement plan that has been scrutinized over the last 2 decades. That same fiduciary focus is starting to hit self-funded health plans. And it's really starting to hit the PBMs because that's where the rubber meets the road. And there's a lack of transparency naturally in the PBM world. And so plan sponsors now have a target on their back as the fiduciary that maybe the outcome isn't great, but do you have a thoughtful process in place to review your PBM and analyze the contract? And that's what is defensible in these court cases. Like, do I have a thoughtful process in place? And some employers do, and some employers don't. And so that's a thing that employers are going to have to track and keep an eye on as these lawsuits start to unfold.
So, Paul, if somebody out there is worried about this and they want to work with you to protect them against these situations, how can they get in touch with you?
Well, carrier pigeon works. Probably best in today's environment is email. And so I can be reached at Paul, so Paul .Ashley, Ashley, at NFP.com, as in NancyFrankPaul.com. So Paul.Ashley at NFP.com. I'm also out there on the Instagram at PE Ashley. And then if you want to talk wine, indie som, like we can go any direction if they want to get a hold of me, right? But probably best for the purpose of PBM thought leadership would be the email, paul.ashley at nfp.com.
Well, that's wonderful. And if they want you to come and host you at the event, get you to talk about the wine, you'll do that for free if they are a nonprofit.
Yeah, if they're a nonprofit, I could be convinced to help a customer out. You never know. A little wine between colleagues is always good, right? In moderation, Ramesh, of course.
That's right. That's right. In fact, they do say in France, a glass of wine every day is actually good for your heart.
That's right. They do say that in France.
Well, this has been a fantastic conversation, a lot of things to learn, and I really appreciate you digging into the details of what are the different structures. We'll add this in the show notes. I think there's some things that you shared with us around those 8 to 10 strategies that are really key in driving these costs down. Anything else you want to leave our audience with before we part?
I would just say that as a self-funded plan sponsor, data is your friend. Use it, and reuse it to make sure that you understand your data, but that you're also creating insights and then taking action off those insights. That clearly is important, not just in the PBM part of your self-funded health plan, but everything you touch and do as a self-funded health plan sponsor. Data is your friend.
That's fantastic. Thank you so much, Paul, for taking the time.
My pleasure.
And I would like to thank Valence Health, our sponsor of this show. Please join us again for another podcast in the series brought to you by HCAA's Voices of Self-Funding. Please like and share so we can build a community of like-minded people. And tell us about topics that we should bring to you next. Please watch your email for updates and upcoming guests. I'm your host, Ramesh Kumar of Zaki Point Health.